welcome our panelists for today. This session is normally streamed on Zoom platform, also on the YouTube channel, which is whose link is going to be shared shortly as soon as we start. Our program runs from now until 1 p.m. So the lineup, we are going to have welcome remarks from Violet Alinda from Twaweza. Then we shall have a presentation of key findings from Marie Nanyanzi, Twaweza, Uganda. We shall then also have a highlight of government policies and EMS strategy. We shall also hear from Kampala Capital City Authority, the strategy for emergency medical services for Kampala, the role of nursing in emergency medical service, and also we shall have existing emergency protocols in private facilities, and also improvement of emergency medical services by health workers. Many would be wondering what emergency medical services is. So I know when Dr. JB is given chance, he will be able to explain what emergency medical services entails. Is Violet already online? I would like to immediately welcome Violet Alinda of Twaweza to make her welcome remark. Thank you.
So I would like to welcome everybody this morning session. I'm Violet Alinda, as already introduced. I live in the Twaweza team, Uganda. Very briefly to mention that Twaweza is a legal organization. We implement our work in Kenya, Tanzania, and Uganda. Health, and most importantly, at the time when every one of us needed correct or accurate and timely information for us to be able to make the right decisions, but most importantly, for us to continue sharing a message of hope that allows Ugandans the opportunity to go through the tough times that we've been dealing with. Of course, I would like to welcome our panelists. They have already been introduced. We are so grateful that you're going to be sharing with us your wisdom. I would like to welcome the media members from the media. You've been our partners and we've worked with you this long. We really do not take your presence for granted because you set aside time every weekend for the last 4 weeks. This is the 5th. We are having this conversation every day, but most importantly, that you've gone out of your way to share this information with the public. We really appreciate these partnerships. And of course, everybody else that has joined in on the line, you're very welcome to this session, and also to my team that have been working behind the scenes, especially Martha, making sure that all these invitations and all these connections are made. Of course, I hope my colleagues from the Dar es Salaam online and the Kenyan team, please, you're all welcome. Please join us and let's listen in. We are looking forward to the many insights and the words of wisdom that will be shared by the experts. Would like to wish you happy engagement. We hope we can continue having these productive conversations, this mechanism going, because without information, without opportunities to have dialogue, without opportunities to have spaces where the experts can tell us how we need to move, life would be very difficult. Thank you so much all, and back to you, Mr. Ainebiona.
Violet, Alina, we are glad to have you join like the rest of the Zoom platform. I would immediately also give an opportunity to Marie Nanyanzi of Twaweza to give us findings on the study done by Sauti za Wananchi on seeking treatment. You're welcome, Marie Nanyanzi.
All right, thank you. So today's presentation is titled Seeking Treatment, and this is feedback from the citizens' views and their behavior on addressing health problems. As Violet has mentioned, we are really a governance organization that looks at getting research or information from the citizens and then give that feedback to the policymakers so that this informs the decision-making process or implementation of different programs. And under the Sauti za Wananchi program, that is Voices of the Citizens, we collect citizens' feedback and share that with different policymakers across different themes. And in this webinar series, we've definitely been talking about health-related issues together with the Ministry of Health. So that is briefly our objective of doing this. Then for the methodology, we have two panels in Uganda under the Sauti za Wananchi program. We have the national panel, and then we have the point of entry panel, which looks at the three districts, that is Kampala, Chotera, and Tororo. For the one that is done on a national level, here we are collecting data from the 15 sub-regions of Uganda, and so that we are able to get feedback that is representative of all the citizens of Uganda, because for that panel, it strictly looks at the citizens of Uganda who are 18 years and above. Then for the point of entry, we look at the residents of the three districts. For both the research, for both the panels, that is the national and the point of entry, we have worked together with UBOS to design the sampling procedure, and our confidence interval for the findings that we share is 95%. So I won't go too much into the methodology, but that is briefly what it is. And we have research permits to do this study also from the Uganda National Council of Science and Technology. So for the point of entry, how we got this, that is for the other members that are attending this series for the first time. So back in May last year, we shared a presentation with the Ministry of Health, that is the Health Promotions Team, and also the Risk Communication Pillar of the National Task Force on COVID. And from those findings, it was quite evident that it was important that we get to understand what the people in the points of entry and also in Kampala think about issues related to COVID-19. So we spoke with our research provider and then got respondents or surveys that have been conducted in the last 3 years. And these we made sure that these have respondents that have been selected randomly. That is when someone goes into the enumeration area or your village, that they're able to, they first list all the respondents in that village and then randomly select households that participate in that survey, because this would ensure that we are comparing the same things over time since they've been selected in a similar manner. And from this, we got our sample of 11,000 respondents in the 3 districts, with Kampala having about 5,000, and then Chotera and Toro having 3,000. Then in Kampala, from the 5,000, we randomly selected, that is from our database of 5,000, we randomly selected 750 respondents to represent the views of the residents of Kampala. Then for Chotera, we selected 600, similarly with Toro, to represent the views of the people that reside in these 2 districts. And that gave us a total of 1,950 respondents. That is for our panel in the 3 districts. I've given you a bit of both because the findings that we're going to share have feedback from both panels. So for our findings, we asked the citizens the last time someone in their household suffered an illness or injury, what was the first action they took? And we looked at data that we have been collecting since 2017 when we started our first panel in Uganda, that is from the national panel. And we have seen that over time, even in as early as 2017, we're seeing that a half of our citizens, that is Ugandans, the first action is to go to a government health facility. And that was similar to what we saw in 2018. Then in 2019, we saw that percentage growing a bit to from a 50% to 57%. And also in 2020, that percentage is still high, with about 56% that turn to a government health facility to seek medical attention in case they get an injury. Then we saw that there's also another group of respondents that also choose to go to a private health facility. And this has been in the 20s since 2017 to 2019. And in 2020, this number dropped slightly to 17%. Then for those that go to a church and mission or mission health facility, this from 2017 to 2019 was about 2% on average. And then in 2020, we saw a slight increase in those as well, with 5%. Then for those that turn to a pharmacy once they get an illness or an injury, this number has continued to drop from 2017 to 2020. I think it could be that people are getting more of a feel of understanding that I ought not treat myself. I should really seek help from the professionals. Then there are also those that go to the local grocery store for medicine. Those are also 6%, similar to those that are going to the pharmacy. Then there are those that use the medicine that is at home or from a friend. That is again, that is also 3%. And this has been consistent from 2017 to 2020. Then there are those that go to a traditional healer. That is about 1%. Then there are those that also do nothing at all. So what we see in summary is that a half of our citizens, they turn to the government health facilities to get treatment. And this has been the case since 2017. So the government health facilities are really the point of hope for most of our citizens. Then we also try to understand this behavior or this kind of response to seeking treatment through that demographics. And we see here that when it comes to those that go to the government health facilities and also those that go to the private health facilities, we see that the wealthier someone is, the more likely that to go to private health facility. And then also those that reside in the urban locations are more likely to go to a private health facility, which again shows us that for the less wealthy population and also those that reside in the rural areas, their hope really rests in the government health facilities. Then we also try to understand, for those that go to the government facilities, the last time they visited those facilities, what were some of the challenges that they experienced while they were there? And we see here that most of the problems that they experienced, or the highest mentioned, was the lack of medicines or other supplies. That was mentioned by 48% of those that had turned to a government health facility. And this data was collected in 2019. Then the other challenge they experienced, that is about 3 in 10, was the long waiting time or the long queues. Then there was also 2 out of 10 that said that there is a lack of attention or respect from the staff in those public health facilities. And away from the data, we've had stories of people giving comments that they are sometimes given when they go to a government health facility. Then the other challenges that they mentioned was the services were too expensive or they are unable to pay. And we know that in some government facilities, there are some drugs that you have to pay for because maybe there is a stock out or one challenge or another. And for those citizens, the 50% or the 56% that turn to these facilities, that becomes a challenge. The 9% mentioned that the doctors were absent when they went to the facility. Then again, the issue of staff being rude. So if we combine this with the lack of attention, there is an issue about the customer experience, or should I say the service experience when they get to those government health facilities. This is a combination of the two, that is about 28%. Then others were mentioning patients sleeping on the floor, that was mentioned by 3%, and then dirty facilities, and 1% mentioned more than one patient on the bed. 33%, for them there was no problem whatsoever when they went to those facilities. But the key challenge we want to emphasize here is the lack of medicines and other supplies when people turn to the government health facilities. Then we also looked at data between December 2019 and December 2020, that is for those 2 months. What is it that happened in terms of what do Ugandans see as the most serious problems facing the country? And in 2019, 42% mentioned that health facilities or diseases were the key issue that was really a problem for our country. Then in December last year, 46% mentioned this. So we see a slight increment in those that were saying that this is a challenge for the country. Other problems that Ugandans are experiencing are the lack of employment. This was mentioned by 33%. And then the high cost of living or the inflation by 31%, mentioned by 31%. And then there is the issue of corruption, which was also mentioned by 21%. Then there's that issue of the infrastructure, that is the road network, that is mentioned by 18%. And then there is hunger or drought, which was mentioned also in December last year by 13%. So from this, we see that again, health is really a matter for the citizens of Uganda. But when we looked at this same data, the same group of respondents, and asked them what is the most serious problem that faces their household experiences, we did see that the order slightly changed. where we now started seeing that the cost of living went to the top, followed by the lack of employment, then health took the third position. And this could be that maybe for those that go to the government facilities, that this probably did not change so much, they have the same challenge, or even those that go to the private facilities, that now the issue of health is comes third compared to the inflation, because if at all for the two areas you have to transact out of pocket, then inflation becomes an issue because it's taking away your money, and yet even health is more demanding. So we think that health issues are really critical, and it's good that we have this evidence here. Then in our panel for Kampala, Chotera, and Toro, there's data that we collected in June, that is the last week of June, and a bit into July. And here, we try to understand who would the residents of these three districts contact in case of a suspected coronavirus patient in their family or among their friends. And here we saw that half of the residents report that they would contact a health worker or a health facility in case of a suspected corona case. It's only in the case of Tororo where we saw that about 3 out of 10 said they would also contact the LC1. But for Kampala, Chotera, they mentioned largely the health facility. So again, this goes to show us that even in the pandemic, the health workers are our trusted alternatives. There are other mentions, for example, a relative or a friend, the Minister of Health, then the COVID task force. This was slightly higher in Chotera with 10% saying that compared to Kampala where 4% mentioned that. Then in Toro, 2% mentioned that they would go to the COVID task force in case there is a suspected coronavirus case. Others mentioned self-treating. Then there's also a mention of going to the police, but these are still very low percentages, less than 3%. Then there is the village health team with 1% mentioning that in Kampala, and also in Chotera 1% mentioning that, with a higher mention in Tororo at 7%. Then we again try to understand what would they do in case somebody had COVID-like symptoms. And in this case, most of the residents of these three districts said they would visit a health facility. Again, it goes to show us the importance of the health facilities. And again, it goes to show that, to highlight that in case of an emergency, because for most people, when you have a COVID case, that really becomes an emergency. And from this point, I think I want to conclude and say that health is seen as the most serious problem facing the country. And we've seen that in the government health facilities, there are a number of challenges that our citizens have experienced. And most mentioned is the lack of medical supplies. Then for the alternative, which is the private health facilities, that is the highest alternative to the government facility. Here, this is most likely to be used by the wealthier residents. So in the end, health facilities are critical to the survival of Ugandans during a pandemic, because for those that will go to the private health facilities, they have to pay out of pocket. And again, we know that we have only of our citizens that have access to health insurance schemes or generally insurance schemes that they can turn to. And at this point, I would like to hand over to the MC and now take us into the feedback from the experts. Thank you so much.
Thank you very much, Marie Nanyanzi. And this is variable feedback about the health service delivery in the country. It's important to note that it's encouraging that more than 50% will always seek health facilities in public facilities. Irrespective of the highlighted challenges, those will be points of focusing on in terms of communication and attitude change, as will be clearly highlighted by the panelists we have here. Since the Director Kampala, Director Dr. Ayen Okero is here, we'll be able to also relate whether some of the issues have been discovered in the health facilities in the urban center. This is I think the fourth webinar we are the fifth webinar we are having. We earlier had one on home-based care. We had one on vaccines. We had one on testing, COVID-19 testing. We had another one on community prescriptions and self-medication. And today, and also we had one on psychosocial support and mental well-being during the COVID-19 pandemic. And today we are privileged to have emergency medical services, which is normally forgotten, and normally think it is only an ambulance. When you talk of emergency medical service, people tend to think it is an ambulance and that's all. But today, the experts in the room will be able to break down what it entails to have emergency medical services in the country. And also, we've seen several ambulance types. We've seen those ones normally bought by the members of parliament. There have been those government has purchased, and recently we now also have bought ambulances. So the public out there would be interested in knowing how do these come into the country, what differentiates one ambulance type from another. When you talk of pre-hospital care, what does this mean? Then emergency emergency departments, what people normally refer to as casualty. What happens at casualty and what services are offered there? But allow me to bring in Dr. John Babbitt Wanyai Nambohe, the Commissioner Emergency Medical Services, who will give us basically a highlight of the government policies and also on emergency medical services strategy. So I would wish Dr. JB tell us a little about the existing government policies and strategies regarding emergency medical services. Dr. JB, you're welcome.
Thank you, our Senior Public Relations Officer, Inaviona Emmanuel. And I would like to start by thanking Twaweza for having supported us to be here today, and also the media and all the people who are listening all through. I'm Dr. John Baptist Wanyana Mbohe, Commissioner for Emergency Medical Services, commonly called Dr. JB, so that becomes easy for you to remember. Emergency Medical Services, this is a new department at the Ministry of Health. This is its 4th year. It came in place in response to outcries for the need to respond to emergencies. When we talk about an emergency, we are referring to a disease or a condition of sudden onset that may threaten part of your body, can be a limb, or threaten your life. So these conditions, we refer to them as emergencies. There are many different types. There may be medical emergencies, could be trauma, it could be maternal obstetric emergencies, it could be mental health emergencies, it could be highly infectious diseases like Ebola, like COVID now, and the others. Some sudden onset conditions could be like, excuse me, like accidents which occur like during landslides, during maybe bombs and so on. So we may have what we call chemical, biological, radiological, and nuclear accidents which may threaten life, and those are classified that way. Emergency medical service system is a subset of the overall healthcare system. And usually in the emergency medical services, we are dealing with 3 areas of focus. We are dealing with the scene of occurrence of the emergency, and we are dealing with the means to take that patient to a definitive facility. We call this transportation, and that is the one which the moderator was referring to as widely known, ambulance service. That is the second arm of the emergency medical services. We also have the third arm, which is the steps we take at the health facility level, at the accident and emergency units, or commonly known as the casualty units. So in order for us to achieve our goal of saving life, this continuum of care should be complete, from the scene of occurrence of the emergency to the accident and the emergency units at the hospital. All this should be in sync. So from 2017 to now, we set up ourselves to set up the emergency medical service system that responds to the needs and wishes of the population. I want to appreciate the presentation made earlier on by Marin Nyanzi about what the population are talking about, things which constrain service delivery. And these are some of the things which we have addressed in our strategic approach. We have developed the National Emergency Medical Services Policy and Strategic Plan. The strategic plan has been approved by the Ministry of Health, while the policy requires cabinet endorsement. And the policy has been submitted by the Honorable Minister of Health to the Cabinet Secretariat. So anytime this will become a point of discussion, and we get a policy direction from cabinet. But it's worthwhile to remember that from 2016 to 2020, the government committed itself to establish a coordinated emergency medical service system. And His Excellency called it having a command system. From that commitment, we have been working towards the realization. Then in 2021 to 2024-25, again, His Excellency made a commitment with Ugandans that we are going to have to establish 14 call and dispatch centers across the country to coordinate the referral system. All this is an additive to make sure the emergency medical services system is operational. Now, I'll give you highlights on these three sections on what appears in our policy. At the scene of care, we have planned to have emergency medical first responders, trainings across so that the people who first arrive at the scene of an occurrence of an emergency, for instance, as we are in this room, if someone collapses, this room we should be able to have the people who are not health workers, but they know how to offer first aid. And the first person to reach should be able to help you to survive. The same as it can occur in a market, in a corporate organization, on the road, and so on. So we have been going through that with our partners, training community first responders to that effect. Also, in respect to response at the scene, we are going to establish a universal access code number. The Uganda Communications Commission has given us 911, which will be a number when we fully functionalize the call and dispatch system. It will be the number because we wanted a number which is easy to remember. The current numbers which we are using are long, about 10 figures. You see, usually I have also at my level, I have to check the number on a script in order to dial it. But we would like a number which someone is in the village, is downtown, but has seen an emergency, just picks that number and is able to call it. So we are working with the partners, Uganda Police Force. We are working with the Maltese International, Coffee, Chai, and others to see that we functionalize this number. And we are going to have the National Call and Dispatch Center within Kampala and 14 other regional call and dispatch centers therein. We have also planned, in response to the scene, to have the reintroduction of first aid trainings in our schools so that every child who has gone through maybe primary level is able to offer first aid, secondary level, tertiary level. And here we are working with the Ministry of Education to realize this. We have worked with the Uganda Red Cross and the Ambulance Care Professionals Association to develop that curriculum to see that that comes. During our days, even when you were in P5, you could know that if someone is bleeding, I need to get something to tie and stop someone from bleeding. The second part, which is widely known, is the transport with care, the ambulance system. Now, the ambulance system is going to be reorganized. The Ministry of Health approved the 2 types of ambulances, one for universal coverage and one for managing severe and critical conditions. The one for universal coverage is known as Type B. It offers basic life support. We equip it with medical equipment, with oxygen, and so on to offer that type of support. This ambulance would be one per health sub-district or constituency. Then we have the type C, which is an intensive care unit ambulance. We intend to have one per regional referral hospital and 5 of them within Kampala metropolitan area. And originally this demand was not as big, but during this time when we have had COVID conditions, we have realized the demand is high. So far now in the country, between 2020 and now, when this demand raised, we procured 5 of the type C ambulances. One was already existing, and we got an additional 4 within the country. And 2 of them are road ambulances, and 3 of them are boat ambulances, type C. We have had to procure 116 type B ambulances. These are equipped to support, and we have trained over 500 emergency care responders to offer the support which we require. Then, for us to function very well in all these ambulances, we need to have that communication system, the call and dispatch system, where you are able to call. And we are working with the KCCA to have that system work within the Kampala metropolitan. The director will expound on that. But we also have previously ambulances which have been existing, 178 of them, but they are not equipped adequately to provide the type of support we require. And these ones, we are going to upgrade them with the equipment. The third area is functionalizing the accident and emergency units in our health facilities. Right from Health Center 4 to the National Referral Hospital, all these areas will have functional accident and emergency units. And when you see from this report from Twaweza, from the community, you see they are talking about medicines, they are talking about long waiting time. By functionalizing the accident and emergency units, we shall have responsive staff, whom we call the emergency care staff, trained with the attitude to make sure that when someone reaches this hospital, the response is quick and efficient. And also the communication system. Sometimes when we are transferring patients to hospitals, you reach the hospital when they are not prepared for you. But when we have a communication system, one in an ambulance or at the scene will call the hospital that I have here a patient who is breathing badly and I'm bringing this patient to hospital. So the hospital gets ready for you. And we would have equipped them with the emergency care packages, emergency care medicines, and this system will be able to operate. We are working with the academia to make sure that the training of emergency care professionals is upped. In 2018, the Ministry of Health supported the training of 14 emergency physicians, and 5 of them have qualified, and we are waiting for the rest. We have also, that's under Mbarara University. We have also Makerere University, which the team has not yet graduated. We have also Rubaga Hospital, which has started a training, a diploma training in emergency medical technicians. These are paramedics. So, in a nutshell, I would like to inform you that government, based on the baseline studies which were done 2017-18, supported by WHO and Makerere School of Public Health. We developed this plan. Then in 2019, this was made real by the World Health Organization resolution. The resolution of the World Health Organization called on member states to establish policies and strategies that can improve emergency care services right from the pre-hospital level to the accident and emergency units up to the critical care units. Thank you so much. That's the brief I can give. Thank you. Good.
Thank you very much. Dr. John Baptist Wanyaye, also commonly known as Dr. JB. We have had the policy framework for emergency medical services in the country. And also we've heard about the plan to establish 14 regional call and dispatch centers across the country. I am made aware that some are already being piloted. I think Masaka and Naguru, that highlight Dr. JB will highlight when another opportunity comes. So we are in Kampala Capital City Authority, where there is a huge concentration of population, health services, majority of the healthcare providers are based in Kampala, and that's where there is even a big population. So this brings a case of how is Kampala prepared for emergency medical services. We have had cases of buildings collapsing, fires. A day ago there was a fire around the, I think that Mulago area near the northern bypass. So how is Kampala ready for this? So Dr. Okero Ayen, could you please tell us about KCCA's strategy for emergency medical services in Kampala?
Thank you, Emma, and all those who are outside there online. Thank you for tuning in. Quickly, just to give you a context, Kampala has an estimated resident population of about 1.75 million. And when you're looking at the day population, estimates go anywhere to 3.5 million during the day. So you'd actually say that each of the individuals, both the residents and the visitors, can actually cause a potential emergency. But when you look at the health facilities across the board, from the health center tools to the hospitals, they are close to 2,000. Again, any of the emergencies can come from any of these facilities that are there. And I'm speaking about Kampala, but looking into the behavior or how people relate and how people move, for operational purposes, it actually say anywhere within, and I always tell people, as long as I can get a taxi to come to Kampala within 45 minutes to 1 hour, operationally, you'd actually think that is where you'd be able to respond. So looking at the strategies, when you look at the first one is, you'd actually say cooperation and partnership. And this comes out clearly is that government may not have the monopoly of the resources, but there may be people, organizations outside there willing to be able to share these resources. So one of the strategies of EMS through cooperation and partnership, you can say, can break it down one into the referral systems, because there is one thing responding to an emergency that occurs in the community, but then the question is, where are you taking them where they can be able to complete the care? And unless you have a clearly defined referral system, you may find it challenging. So again, making sure that the referral systems are in place, people are going to the right place for the right care. Rather than you taking what we would call empty referrals, you're going to a facility or you're taken to a facility where there isn't any added care that may be beneficial. So as you go again, you have to, one of our strategies is making sure that the referral system in the city is clearly defined and people need to know where to go. And as part of the referral system, we did a census. And part of that census was to create a medical directorate. And this medical directorate is to know if you go to facility X, Y, and Z, what are the services provided here and what is the scope. And the essence of this was to feed into the other strategies that I'll quickly go through. So the next is again use of ICT. We are trying to leverage the use of ICT, information communication technology, to improve on the EMS services. Because once you have a call and dispatch center, it's critical that people can get to you in real time, but people can also be able to get to you at a near to no cost. So use of those who have mobile phones, we have developed an application that we are piloting. Very soon it will come out. Just like you can order for a self-border, we want you to be able to order for and to be able to request or to be responded to by using an application. So very soon with Ministry of Health that should be able to come out. So use of ICT is critical. As I said, that the other strategy is how do we make EMS, as I say, low cost or near to zero cost. And as you know that you do not plan to have an emergency. It occurs unexpectedly. So again, working with partners, working with the ministry, our strategy is to make sure that EMS is near to no cost for persons who are outside there. And this will lead into affordability and accessibility. So all those tend to fit in together. As I said earlier, we also look at a metropolitan approach. Many people may not know that Chireka is in Wakiso. Many people may not know that Nambole is in Wakiso. But again, when you look at the estimates, they will say if your response time is supposed to be anywhere between 10 to 15 minutes, and probably 5 or 10 minutes, and an ambulance is moving at 70 kilometers an hour average, how far can that take you? So the boundary to which an ambulance is moving at a straight line at 70 kilometers per hour for 10 minutes, that is what would be your boundary. So you move away from geographical boundaries to see where you can then work within that golden period to be able to evacuate. So again, that is moving away from the traditional, but again, where you can be able to stretch. The last one is the strategy, risk-based. You look at a risk-based approach and you profile. When we were in medical school, we used to be told that common things occur commonly and they tend to be commonly ignored. So once you profile, you get to know what is the chance that such an event is going to occur in a certain area. But with EMS, you don't ignore. So that leads into the areas of black spots. So once you know that here accidents tend to occur, what kind of accidents, that then helps you to build your capacity to respond to particular accidents. We have had accidents on the Northern Bypass where fuel tankers have overturned and caught on fire. I think that occurred sometime, and that was one event. We know the black spots in Kampala whereby when floods do occur, probably people tend to get affected. We'd even profile and say within every 2 years, we used to have cholera outbreaks in Kampala. Right now, they're no longer there because we have had deliberate strategies to be able to mitigate against that. So again, the strategy of having risk-based profiling to respond to EMS is critical. So very quickly, those are the strategies of KCCA broadly, and that is how we want to bring EMS to your doorsteps. And as someone said, that the sound of an ambulance or the sound of someone knocking on your door when there's an emergency could be one of the best sounds we'd actually want to have. And that is what the Ministry of Health would want to do. Thank you very much.
Thank you very much, Dr. Okero, for giving us an insight into Kampala and the Kampala metropolitan area. I know, although the study earlier presented by Twaweza did not factor in access to an ambulance, I know during this COVID time, many people have been evacuated by ambulances, and they have accessed these ambulances through the Ministry of Health toll-free line. And wherever you stay, I think there has been a characteristic of an ambulance siren at least every like 20 minutes. You would hear an ambulance. And these ambulances are under KCCA, under the Ministry of Health, and also some private providers. Moving on, there are some questions that have come through the Zoom platform, and I think the panelists, I can read them such that when your turn comes and you have something to highlight, you can highlight. There's a question which says, was there an attempt to stratify the private health facilities into pure private for profit? Because someone is asking, what does the term private not for profit mean? Lumping them together may cause information loss because they operate differently. So I think this was to Twaweza based on their study, because I think they lumped them as private, yet they are private for not for profit. But in case one of the panelists can help us break down the terminologies and the abbreviations. Another question coming through the Zoom platform is, having only 50% of the respondents choosing first to go to a health facility should not be exciting. It is worrying. We should be having a rate close to 100%. This means there is a lot of work to do to improve health service seeking behaviors. We totally agree with this submission. The other is, having a majority of health seekers going to government facility is not only because they prefer to go there, but more because the government health facilities are the big majority, especially at the health center level. Also that we agree with the submission. Differentiate between faith-based facilities and private ones, and are they supposed to charge differently? Those are some of the concerns. People who are joining through YouTube, we've shared the YouTube link. People who are joining via Zoom, we will welcome more questions, and also the media within the room will later on be given an opportunity to ask questions. I would now give an opportunity to Sister Grace. Dr. Grace Nanyondo, who is the medical director of Rubaga Hospital. The question here is, are there any existing protocols within private facilities that allow patients with emergencies to be managed before making payments? That is one of the critical questions. And also maybe later on, Dr. JB, when an opportunity comes to you, you need to clarify on what exactly should happen for some life to be saved, not to be lost. Because if I am struggling and the first thing I'm being told, deposit 5 million, which has been the case in a number of private facilities, how does the policy, emergency,
since it's still a work in progress, the unit is a high time that discussion actually came. Dr. Grace, the floor is yours to respond to that question and any other highlight. Thank you.
Thank you very much, Emma, and the rest of my fellow panelists, and the viewers out there. Thank you for the question. And this question, I will answer it basing on the experience I have. And this experience is more of PNFP, not private, not for profit. Though I have shared with my colleagues from there, so I will be sharing to you from the views I got from them, but the experience I have is more of PNFP and one more of Lubaga Hospital. COVID-19 is a unique illness that struck us before we knew it.
Grace, you could first explain what it means by profit, a private, not for profit.
Thank you very much,
and
Emma.
Let's avoid the jargon. When we say PNFP, the lay person out there might not know what it means.
I understand. Okay, private not-for-profit is a stratification of our healthy system in Uganda, and these are hospitals or healthy facilities that are faith-based. They can be Catholic-based, they can be Muslim-based, they can be Protestant-based. And they treat patients at a cost that does not incur a lot of profit, but at a cost a patient can afford and can as well help sustain a hospital that you can come back next time and find it not collapsed. And then total private, these are hospitals that treat you at the same time making profit from the services they are giving you. And private, public hospitals, these are government-based hospitals. They offer care at least no cost, all affordable cost that has agreed by the cost-sharing partner, rather members coming to the government facility. I think we have understood that. And then the question was, is there a protocol that patients should first pay deposit before they are treated? And this is what I was going to answer. But I wanted to first give a baseline of what COVID is, a history of what COVID is, and how it is different from other illnesses. Initially, people didn't know that COVID is quite a unique and a very expensive illness to treat. And they thought COVID is any other business. We can get numbers, treat, and at the end of it all, gain profit at the level we treat other patients. And they would admit and treat, only to realize that COVID patient demands are very expensive to fulfill, and to save a COVID patient, you must have used to clearly, totally exhausted your stores, both human resource and supplies. So when they opened their eyes, they revisited the billing of the care given to the COVID patients. Some hospitals were exorbitantly very expensive. The PNFP, because they are known for their affordability, increased a bit, but it still became expensive for the common patients we normally treat. Then this business of letting a patient know that you have to pay a deposit of a little more than a general other patient was to test their commitment and to let them know that really what we are venturing in is more expensive than any other illnesses, and to test their commitment that we shall be able to pay despite the little increment in the management of this illness. However, it did not mean that we don't touch patients before they have deposited. No. If you can imagine a patient who comes in breathless, you can never even think of money first time. You first receive this patient, put on a coat, put oxygen, look for emergency resuscitation, first work as a team, make sure this patient is stable, then start taking history, and then start explaining the necessary requirements that may be required. And because of the high cost, we are kindly requiring you to deposit a little more than you would have deposited on a patient who is suffering from another illness, who will stay 3-4 days in the hospital and get cured. And for your information, I did a calculation of the average length of stay of COVID patients of the first wave and this wave. I noted the first wave was a bit kind, that patients would come and stay for 5 to 7 days, get better, and go home. But this wave, patient would come, you admit, one who has been better can worsen from the hospital. And they would take the average length of stay was about 2 to 3 weeks. You can imagine 2 to 3 weeks with a patient who requires expensive, who requires HDU. HDU is high dependence unit care or ICU care. That is just average. Others would go up to a month. And then the cost would pile, and then at the end of it, they would not manage to pay. So this was to test their commitment and to tell them that it's going to be a little more, please organize more funds. But it wasn't that we don't touch you before paying deposit. Thank you.
Dr. Grace Nanyondo for giving us a stratification of these health facilities and also a bit of an insight of what it takes to attend to a COVID-19 patient. And I'm glad to note that the first responsibility of a health facility is to save a life before the money bit comes in. But unfortunately, some relatives and also some members of the population have lost their loved ones in ambulances. Either facilities have totally refused to admit them, or there has also been a challenge to have communication. So the subsequent speakers will be highlighting about the process. If I called and said, my patient is not breathing well, I've called an ambulance, and the ambulance has come, what happens? And what is the medical and expert advice? Because there are some delays that are existent in our system that we need to rectify. But how best and what are the protocols of handling this? But I will first give an opportunity to Sister Judith Chumuhendo, who has been working in the COVID treatment unit at Murago. And I would like to know the role of nursing or nurses in emergencies like COVID, because personally, when I was admitted, the persons who could check on me, the cadre of health workers, were the nurses from time to time. Even at first, when I was first put at the presumptive ward. So, and also, as you heard, the survey talked of attitude of our health workers. And in COVID, because you come in with a lot of fear, it is likely to worsen. And that's why we've heard of terms like psychological COVID. So I know at Murago there are interventions like a help desk to put in touch patients with their families. Because with COVID, there's nothing that we are going to visit someone, see you on your hospital bed. So this puts the entire responsibility of the patient care during COVID to the nurse. So Sister Judith Chumuhendo, give us the insights of what your experience has been, and also what should the nurses do and what are their responsibilities. Thank you.
Yeah. Thank you very much, Emma, and the viewers outside there. I'm called Chumuhendo Judith, not Chumuhendo. I'm a nurse attached to Mulago National Referral Hospital. CTU means the Corona Treatment Unit. I'm going to request the team, before I proceed, we know very well that we've lost very many health workers out there, which is so sad. Can we first have a minute, or a quarter minute, to remember our colleagues? May their sorrows rest in eternal peace. I mean, it's so stressful when it comes to such situations, especially when we lose our colleagues. Remember, we are the frontliners. Imagine you've gone to fight, you see the commander dying. Always ask yourself, who is the next? Things have changed, members. Others may believe, others may not believe. For us, through a best experience I've gone through in Mulago CTU, we believe that the security begins with health workers. You may ask yourself, how would we do it? We've been observing standard operating procedures. How would we do it? We maintain social distancing whenever you're on duty, proper or adequate use of proper PPEs. PPEs in full means personal protective equipment, and hand washing, of course. And we believe that for us, our care starts right from the time you come on the triage. That's why I'm telling you that things have changed. We have a functional triage from morning to, it is continuous. Whether Christmas, whether first of whatever, we are there for our patients. We know that we have different types of patients. We have those who come in walking. We have those who come in ambulance. We have those who come in private cars, but we don't segregate. We usually begin with, we have different colors, and we give those colors according to patient's clinical presentation or the severity. We have red. If you came to our triage and we gave you red color, it means that there is life-threatening, so we need to intervene immediately without wasting time. We have yellow also, which is emergency. The last color is yellow. This one, if you came and we gave it to you, you are either good to go to OPD, out to medical patient, or you can wait for a while. On our triage, we have a well-trained team where we have qualified doctors, nurses. We don't work alone, we have support staff. These health workers, they are able to assess our patients, they are able to evaluate, they are able to intervene where necessarily, and we follow admitting or admission criteria. Sometimes we are being notified, as Dr. Brett said. They can call us. We are bringing a patient in severe distress. Then we plan accordingly. This one who come, still we triage them accordingly. I've said that. Then we do quick assessment, but it depends on the type of the condition you have. If, for example, you came in severe distress, we just do quick assessment. Then we straight away we take you for admission, either HDU or intensive care unit. Then in there we can also still have some few investigations done. We know very well these patients, they have some comorbidities, and it is this time of triage where we can capture them. So we give them appropriate treatment. We take some vitals. These are signs and symptoms. For example, we have things like we take blood pressure. We can also see your level of your glucose you have in the body. Then we take also, if we see things, of course there we call for help. We work as a team, inform other team members to come and give a hand. Then we can also, we document whatever we do. We make sure that it is being documented. We believe in nursing. If you do something and you don't document, you've not done it. And what we usually do, we encourage these patients to be prompt. And I've said from the beginning, our services are not, we don't segregate. We don't mind where you come from. The services are the same. Then we keep in touch with the relatives. We tell them how the patient is faring on. We do we do so many things. We follow the ABCD there. We have to check whether the airway is parted. We also check, how are you breathing? Do you need oxygen, for example? We keep evaluating. We also assess for disabilities. For example, you have come with us with COVID. Do you have any disability? Maybe you have maybe accident, maybe you have got a trauma, you maybe have got a fracture. We also assess for that. When also we have exposure, like the environment where you are on your triage, is there anything which can also put you at risk again? If you came in, for example, with COVID, we don't want you to go back with any problem from our area there. Then, of course, we follow IPC protocols as much as we are there. IPC stands for Infection Prevention and Control. We keep emphasizing these patients and their relatives to social distance themselves, masks on all the time, social distancing. Then we give emergency drugs where possible, and we secure lines. The treatment is continuous right from the triage up to the ward. I know some people may wonder why you said maybe we give drugs. Some people may wonder how, but for us in Mulago on triage, we give drugs. For example, if you came and we found maybe your level sugars are low, we put on a line, we give you drugs until we stabilize you. Once you stabilize, then we transfer you to your mother ward. And we do so many things as nurses. If at all you're not eating, maybe you're unconscious, we insert in NG tube, that is the nasogastric tube, so that you're able to feed. We pass catheters so that we monitor the in and output of the balanced fluid charts, if possible. Then we also have to continue reviewing. Reviewing is continuous. Each minute, each day, a patient just comes, our review continues. Then we keep also doing other things like counseling and the psychosocial team. We have it on the ground. We know very well COVID is a new disease. All of us, everybody is puzzled whether the patient will recover. Once you get COVID, is there hope of you going back? So we keep encouraging our patients, take heart, relax, take your medication as written by the doctors. Then also, we talk to the relatives what they should bring to us. We've been seeing scenarios where attendants, they've been bringing funny things like alcohol. They bring herbs in the hospital. So it is our role as nurses to tell them what they should bring. We have also visitation hours. We tell them when they should come and visit their dear ones, but we don't let them in. We have a psychosocial table where they come and we keep giving them updates of their patients. Reason being, we don't allow these attendants to come in to spread more the infection to the community. Then we talk to them about, when you are inside there, people really have given up. We bring in psychosocial to maybe talk about the religious issues. But I thank God that people are getting saved. You can't believe. Tell them, talk to them, inspire them. They should never give up. And as nurses, I have to tell you that our care is continuous. It has no limit. It is continuous from day one until you come back to us. I think I can stop there.
Sister Judith Kumuhendo, and apologies for having wrongly pronounced your name earlier.
It's okay.
You have really walked us through the processes the patients go through, most especially COVID and emergency patients that present at Mulago and any other facility. I hope that is the practice and standard. A reminder, this is our 5th webinar, and this has been done in partnership by the Ministry of Health and its partner, Twaweza. and this is the 5th. We hope to have several other engagements. I would like to salute people who are joining via the YouTube channel. I can see comments on social media, and we are streaming on several platforms. On Facebook, we are having Twaweza Uganda on YouTube, Media Challenge. The gentlemen you see in overalls are from the Media Challenge Initiative, who are our partners and providing the technological support. And they have been with us all through, so we are grateful the Media Challenge Initiative for this quality technology. So we are also streaming on the Media Challenge Initiative, Facebook page, YouTube, and Twitter. Thank you. I'm going to bring in Dr. Annette Alenyo Ngabirano, who is an emergency physician and a technical advisor on emergency medical services to the Ministry of Health. And I think she will be combing through what might have been left behind. But she will also tell us about improvement of EMS services by health workers. Allow me highlight some of the questions that have come in since our earlier set of questions. These are coming through the Zoom channel and also on social media. One is, as I was saying, I would like to see KCCA and Ministry of Health Medical Services work together, as has always been the case. Is there some zoning in the emergency medical services to help provide quicker response? Number two, how can we make EMS services more reliable and affordable? Response time should be less than 10 minutes around Kampala, for example. This is KCCA and the ministry. I think these are good comments. We have over 70 people on Zoom, and they are following closely. Number three is there are situations where government ambulances have no fuel to run them. How is government positioned to handle? Can we have a list of contacts for EMS service providers, including private hospitals and private not-for-profit? There's another sheet that came through from a journalist who is within here, and these are specifically to Dr. JB. Let him give more clarification on the development of curriculum for first aid. And are there cases of students who have died due to failure to access first aid? On the issue of accidents, are there statistics of people who have lost lives due to failure to get immediate help? This goes to Rubaga. In line with COVID, on the issue of accumulated medical bills, what happens if the patient fails to foot the bill? Do they confiscate the body? Thank you. I'm going to bring in Dr. Annette, who has been really handy into handling COVID-19 cases, I think from the onset and prior to the COVID-19 outbreak. And will be able to also paint for us a picture, because I know she is always also almost like a call center of patients and how they are being managed to get in touch with the rapid responders. So, Dr. Annette, could you pick two things that would improve the management of emergencies by health workers, but also give a highlight to some of the questions that have been asked, and also what has been the experience during COVID-19? Where are we doing it right, and where do we need to improve? Thank you.
All right. Thank you very much, Emma, my fellow panelists, and all our participants physically and online I'll reintroduce myself for anyone who might have missed it. I'm Dr. Annette Alenyo Ngavirano, emergency physician, and I work with the Ministry of Health as a technical advisor for the Department of Emergency Medical Services. So I'll just pick 2 questions and leave the rest for my colleagues to answer, and that is before I respond to Emma's question. So KCC and Ministry are working together. I think this is, first of all, very evident here. We have the Commissioner for EMS on the same panel with the KCCA Director for Public Health, but also beyond what we are obviously seeing, we, especially in this second COVID wave, have intentionally worked together. We did work together in the first wave, but for the second wave, created the Metro Emergency Medical Services, which is a combination of all the strengths from the Ministry of Health, KCCA, and also working with Uganda Red Cross. And if many of you perhaps have needed an ambulance in the past 2 months, you have dialed the 0800 990000 number that takes you to the KCCA Call and Dispatch Center, and the response teams are from both from KCCA, from Ministry, and also the Uganda Red Cross. So the other question I would like to perhaps pick on is about reliability and affordability of EMS. Yes, EMS is an expensive venture. If you look at the costing that was done for developing a full EMS system by the African Federation for Emergency Medicine, a commissioner will agree with me, it seemed like an impossibility if you look at the numbers. And so what we prefer to do is look at the entire system, pick on low-hanging fruit that can improve our EMS system, but also lean heavily on partnership and partners and their support, and then use perhaps brain is the easiest way I can say. Think of low-cost things that we can do that can improve our EMS system, and we've been doing a lot of that. So I'll just pick on 3 things really for me that stand out for us to improve our EMS system. And the first for everything really, as far as improving any system, is leadership that is dedicated and committed to improving EMS, and that appreciates the need and the investments that need to go into building an EMS system. And I'm glad to say that as a country, we do have that leadership across all levels of leadership. Now, the 2 other things that I would like to pick up are a bit technical, and the first one is training. There's 2 types of training, and the first is in-service training, short courses, and things that we do to improve skills and knowledge of people that are already working in areas of concern to emergencies. But the second one is professional training. Now, I did my master's in emergency medicine very far from Uganda. I studied in Cape Town in South Africa in 2015, and that was because there was no master's in emergency medicine in the entire country. And so I had to travel and incur quite a lot of costs just to be trained. 6 years from that time, we now have 2 postgraduate training programs in emergency medicine, in Mbarara and in Makerere universities. We also have a course for critical care nurses in Mbarara. And the big gap for us perhaps is the pre-hospital emergency care providers. Sister has given a very good description of what happens to patients when they get to facilities. But patients don't teleport from where the emergency has occurred to a facility. There's a big block of what we call pre-hospital care. And emergencies happen in communities, emergencies happen at home, or emergencies may happen in a very small facility. For a patient to be moved safely from where an emergency has occurred is a very important and delicate thing that we have had to manage with COVID. Sometimes, and many times, we have won simply because we have learned lessons and continuously improved our approach to moving patients, but also because we've had support from the community. So you do have a role in how your emergency is managed. And the first is for you to know how to access the system. So for the moment, and I'm going to repeat this number, for the moment, if you have an emergency within the Greater Kampala Metropolitan, and that is Kampala, Wakiso, and Mukono, please remember this number, 0800 990000. When you use that, it will enable you to access the health system wherever you are in these areas, and you'll be able to have a team respond to you. Beyond Kampala, and we have to think as a country, beyond Kampala, the Commissioner mentioned the formation of regionalized EMS services. Over the next few weeks, we will definitely be rolling out numbers that you can also call, and you'll be able, you may not have a call center immediately set up, but you will have someone who can guide you and provide the initial help. So training, very important to have a professional team that responds to emergencies. We have moved on from the days of drivers and vehicles moving to pick dying patients. That is not acceptable, that shouldn't happen. So ambulances have two things that happen. There is the transportation, someone to weave through traffic and to move the vehicle from point A to point B, but also, and very important, you have someone at the back of the ambulance with a patient initiating care right from home. And with COVID patients, you've seen the need for oxygen. The oxygen has to be started immediately for some patients and continued throughout care until we reach the emergency facility, where we can then hand over to the facility-based team. The second thing I'm going to comment on, and this is another low-hanging fruit for us, is protocolized care. So emergency care has a systematic way in which it should be done so that we don't miss patients who are very sick, but also so people don't die while they're in front of us. Can you imagine how sad it is? And one of my mentors taught me a lesson she also learned from her mentor. And she told me, and thank you for this lesson, Dr. Jane Nachibuka, she told me that many times patients have struggled so much to get from where they've had their emergency to reach the facility. They've made phone calls, they've incurred costs, they've called everyone they know in their community, and they have finally arrived. If they're unlucky, they have had to not use an ambulance. Dr. Keller referred to an ambulance sometimes being the best sound you probably have had. In the event that you've not had that sound and you've gone through a process and arrived at a facility, how would you feel if your patient was not given the same dedication that you as a family have been doing to get your patient to health? And you get there and the health actually does not respond to you and your patient actually dies. So we need principles to apply, and one of these principles, of course, is a strong referral system. There must be a system where patients do not need to struggle to get their loved ones to care. The second is simple treatment issues, triaging a patient, and I'm very glad Sister Judith has mentioned it. So triage, recognizing who is the sickest and who we should attend to. And this message also goes out to the public. When you come to a hospital and there is a triage going on, the hospital doesn't work like a hotel where the waiter serves you on a first come, first served basis. In hospitals, it is reversed, and we intentionally address the sickest patients first. And that is why we sort patients through a process called triage, so that we identify who will die fastest, and then we address and stop that emergency from proceeding to take this patient's life. The other is, of course, simple principles, and this is for health workers. A, B, C, D approach to managing patients. Recognize an emergency, make deliberate efforts to resuscitate this patient systematically, and then finally, and very important to a referral system, ensure the patient goes to the place where they will receive the most appropriate care for them. If a patient has an accident and has injured their brain, you know that this patient needs to go to a facility with a neurosurgeon, with imaging that is required, with a theater capacity, with an HD, with an ICU. do not then refer the patient to a facility where they will not receive that. And that is why principles like mapping facilities and their capacity is very important, and I'm glad that the KCCA team has done it. This is something that should happen across the country, and health workers should know the capacity of which facility they need to refer a patient to. So those are just a few low-hanging things that we can do. They don't take a lot of things, and guidelines and protocols are not complicated. We have a lot of evidence in literature, in our medical schools. There's a lot of evidence and guidelines that we simply need to package well and push and ensure that health workers adhere to these simple protocols and guidelines and improve care for our emergencies. Specifically related to COVID, I see Emma is still a bit held up. Specifically related to COVID, we've actually done the same things. We have trained over 500 providers in pre-hospital care across the country. We've also had professional trainings and professionals coming out of their training academic programs, critical care nurses who we have included in the system. You've seen adverts going out for emergency care providers, for EMTs. There is an intention to recruit professionals so that the quality of our care improves and is better professionalized. We've also developed a number of protocols and guidelines for managing patients pre-hospital and also in hospital. We have a clear referral process that we've been using for COVID that has helped us improve a lot of our care and averted a lot of death. We've developed specific guidelines on how you should escalate oxygen care, even in ambulances, and how you can do simple things and simple maneuvers to improve patient outcome. Thank you.
Thank you very much, Dr. Annette. And I've just seen a comment, which is a compliment from someone joining via Zoom, that thank you for your passion for emergency medical services. And also there is a compliment saying thanks a lot for these good educative messages about COVID-19. So I will first give an opportunity for each and every panelist to respond to some of the questions before we take on the other segment. And also, I would also request the journalists in the room to ask their questions if they have. So, do we have questions from inside here? Yes, please, let's first have questions. Your name, please, and media house you're coming from.
Thank you so much. My name is Vincent Sidiko. I'm a journalist from Radio 1 and Akamoz. I don't have a few here. Maybe if I forget, there's something we overlook. It's about the treatment, the kind of reception we get at the emergency points, casualty and things of the kind. I'm one of the victims. I got an accident, a nasty one, and I had a very nasty one. But when I reached there, attitude of your health workers, is it bias that is part of your training? Maybe that's a lighter note. It's bias part of your training because before they even listen to you, someone just put, there's no kindness in the way they do their things. I don't know. That's a good thing I have someone now to address it to. Mr. Commissioner, is it part of the training of your people? Now, the questions. There's a concern on the cost. When you call on to the government ambulance, or anyone with an ambulance, they have rates they will charge you. But this mostly applies to private health facilities. Is there any standardization in the costs of ambulance systems for those that are not public. I'm talking the private. Any institution you will call, maybe, I don't want to mention hospitals here, but you'll hear they're in hundreds of thousands of shillings to just transport you to a health facility. What is so unique about that emergency evacuation in terms of cost? Two, the policy. Mr. Commissioner, you've talked about this policy for now over 2 years. I remember last time you talked about it, and the minister herself talked about the integration, a lot of things embodied in there. When do we should we expect this to pass, so that it's out of the books and it's now practical? Because it's written in book, but people have waited and waited for long. Finally, the report cited, brought out something that the wealthier we get, the more we shun public health facilities. A clear vote of no confidence maybe in the system, because the richer person will be availed to options. And if they have, and they can't opt for a government facility. In your view, well, as they brought out the things of lack of medical supplies and things of the kind, what do you think can be done within the available means, minus those policies that are not coming to pass, but in the real thing, in the real time, to say that people can really trust you guys and see that your priority in terms of preference?
Vincent, we can have another question.
Thank you. My name is Jingo Francis. I work with NTV. My question may be clarification from Dr. JB. You talked about training the young people and first aid treatment, and you want to take this to schools. I presume that this, you will start it with right from the grassroots, even from the nursery. If you want to build that system very well for the public to be able to respond adequately, I just want to know, how are you going to do this? Are you developing a curriculum with the Ministry of Education, right from primary up to the university? How is this going to be done to be able to teach the young people, be able to have knowledge on how to respond on treatment? Thank you.
Thank you very much. My name is Dennis Chove. I report for Bukele TV. Dr. JB, could you please rate how many lives you would save if we're strong at first aid? Thank you. Could you, how many lives would we be in position to save if we're strong at first aid and people, that the first responders know actually what to get to?
Thank you very much. I would request Dr. JB to lead in the response of questions, and we'll give everyone an opportunity to respond to the arising questions. Thank you.
Thank you so much, Emma, for the moderation, fellow panelists, and all those who have given us the questions and the participants online. Vincent brings a common scenario about attitude. Many people have raised this issue. that when they reach the healthcare facility in an emergency situation, usually when you are an emergency patient, you are desperate, you are looking out for who can be able to help, and he puts it that they handle you with no kindness. Of course, there are many factors which affect the responsiveness of health workers. Sometimes you find that people are overworked. Sometimes it is having to attend to another one who is more critical, as Sister was giving you the triage process. So it's a combination of issues. But what you bring out, which is significant, which we have been looking at, is the issue of training. Training, during the training process, if you have been trained to be responsive and have the right attitude at the time of desperation, at the time when people need your help, the way you approach a patient is different. That is why in the policy, I don't know whether I carried on here. Yes, in the policy, we bring it out quite clearly that we would like to have those cadres that are responsive. In the minister's forward, she states that we need to build that cadre of staff, and I will quote here, that emergency and acute care is a critical healthcare service that demands for a wide spectrum of skills and knowledge of many medical disciplines. The interventions provided along this pathway make a difference between life and death. The emergency care providers should be knowledgeable, skilled, but above all have a strong evangelical heart that works under very challenging circumstances. What I want to bring out is that statement, strong evangelical heart, a heart of an angel, if there exists something like that. But that's what the message is bringing, that during that critical time when I need care, I need that health worker with that heart which is ready to give me the care I desire. And that is why we are looking out that we need to build this system of responders who know they are working in a difficult environment, but at the same time they should have that heart to provide the care. And that is why these trainings are ongoing. The trainings are ongoing. Dr. Allen was giving you in-service and pre-service trainings. The emphasis is to have a highly skilled officer, but also a responsive one. Because it gives no essence if you are highly skilled and you are not able, you are just looking at someone who desperately needs you. And this is something which, when this system is fully functional, it will be able to address. The 500 health workers whom we have trained, whom Dr. Lenyo was telling you, one of the emphatic areas is the issue of attitude. And we hope when we build a critical mass, we shall come back after maybe a few years and receive a report of what is happening in the accident and the emergency units in the country. On the issue of On the issue of standardization of costs, which you have brought up, especially for private sector, Sister, I think, would add us a word there, but I would like to bring it to your knowledge that members, health services are very expensive. The other time I was in Parliament and I was estimating the costs in Kampala of moving a patient in an ambulance from wherever community-based, maybe it's at home deteriorating, up to maybe Mulago. And I told them it takes up to 200,000 for about one patient. Exactly, I told them 196,000. And in a day, when you transport 5 patients, it is something like 980,000. This money is based on about 6 items which are critical in that ambulance. One is you must be able to put fuel in the ambulance, and the average fuel we use around Kampala is 15 liters per movement. Now we also pay the health care providers in the ambulance. We pay them a risk allowance, the driver and the nurse or the emergency medical technician. And the Minister of Public Service approved 80,000 shillings for each, that is 160,000. But we pay them per day, we don't pay them per patient. That's why you see that it's divided. Then 3, we have costs for personal protective equipment. There are things which these people dress. Sister, I think, described something. There are PPEs, and one coverall, one for one person which he puts on, the coverall is 100,000. Now when you add on these other items, the cost of that dressing alone is over 180,000. Just PPE. That's for one person. Now the 4th is the oxygen we use. The oxygen we use in that ambulance, each cylinder refilling is 30,000. These small cylinders we use in the ambulance. And a patient may use 1 or 2. Then another item to that are medicines. Sister was talking about emergency medicines we use. Those drugs we use, that is also another cost. The other one is the vehicle itself, its repairs and maintenance. Usually, on average, we calculate that each quarter, the vehicle needs, it depends on its use. It needs to be serviced, it needs to be repaired, if it gets an accident. So when you calculate that, it brings a high cost. So, Vincent, the whole thing is, why I explain this is to appreciate that when government evacuates one patient, it's a big cost, but people will not realize that it's a cost. Now, when it comes to a private service provider, he calculates all of those and says, pay 500,000 for me to move. And for you, you had the 50,000 or 100. And says, I can't move. Please pay everything. So that is the kind of problem. The other problem, which could be a public sector problem, which we are managing, which I keep hearing, is that some of the unscrupulous workers, our workers, you will send them to evacuate a patient and says, tebansasula mpayo mitwalo 5. So that one is something which we are fighting. We have been able to tell all the public service workers that provided a service, and actually I want to confirm to you that all these people, government may delay to pay, but finally pays. The PS has been paying all these people. So no ambulance provider should be able who works in government should be able to charge anybody for any service provided. Then, of course, this is an interesting one, which probably, let me answer this one at our next meeting on the issue of the delay of the policy. I don't have immediate answers apart from what I gave, that the minister has submitted it to the cabinet secretariat. Now it depends on that team there if they put us on an agenda. We got even a cabinet number, so I am hoping that it will, but I'll answer better after consulting with the PS and the minister on what will go on. The last one from Vincent was wealthier people are opting for private. Now, I have had a chance to move to several of these countries, and both government and private provide health services. And because every health service is a cost, where they have a national health insurance scheme, the government pays you for the type of service you offer, whether you are government, private, not for profit. That health insurance scheme compensates you. So it creates competition between the government hospital, the missionary hospital, and the private hospital. And sometimes you have found that people are even preferring government, but where it is assumed that government has already paid, sometimes what makes people move away is because of what you have called attitude. If we become slow in attending to people. But me, from the Faweza report, I became happy because they said previously it was at 50%, and then after a year also, it is now 57%. Now, this means we are doing something good. 7% increase, because a percentage should not be taken literally that it is small. We are now going towards 60. And I think that with the investment which the government is putting in the health sector now, maybe after a year or so, we may be at 70. And our target is for us to perform as good as 80. The other 10, 20%, of course, you will never reach the real 100%. But I think there is some hope. Now, you have seen the other time there is a honorable MP who was testifying, telling you that the COVID-19 treatment units, which are the best in the country, are what? Government. Now, if someone who has been talking the other side tells you, then what other testimony do you want? That testimony is almost like from God, telling you exactly. So there is improvement in the government system, but we don't say that's enough. We have got to keep improving until we reach a satisfaction level which our country requires. Now, jingle from NTV. Yes, training young people, I think my colleagues will add on this, but our thinking is that when we train you early, you grow with that culture of responsiveness. Some of you, I think you have observed, okay, let me give an example. People get an accident on the road. In our situation, the first people to arrive at the scene, they are not looking at saving life. They are searching pockets, they are checking for people's bags, and they are running off, not knowing that God has called you to be the first one at the scene. You can help this patient to survive. So training children early, which we have planned to do with discussion with the Ministry of Education. We think it can be like, those days we had something called PE. During PE lessons, they would train you all those things of first aid. We think that if we go back, we can have that type of training, but we are going to discuss with the Ministry of Education. We have developed a curriculum, but it is them who know what can we give someone in primary, what can we give one in secondary, what can we give one in nursery, and so on. But for us, the drive is to have it in schools. In the UK, all the schools, it's a must that your curriculum should reflect first aid training. And I think Dr. Ian will add on that point. And then I think let me leave this one for Dr. Annette. How many lives can, this is from Dennis Chove, how many lives can we be able to save? It has been calculated very well, and that is why emergency care system is a focus, and that's why WHO made a pronouncement last year. And I'll start with Annette to respond to that. Then I have additions on first aid from Ian. Then sister can finish with the ambulance costs in private. I think, Emma, you allow me to do that?
For responses from Dr. Okero to his questions and those that came from online. But also there is a question, does EMS department under MOH have an independent budget? That also needs to be clarified.
Thank you for those wonderful questions. Just clarify on wealth and health services. I'll give you the example of Kampala, because I think that's where probably more of the wealthy tend to stay. And the public facilities are a minority. I have close to, I think, 1,984 health facilities in Kampala, but about 25 are public. That's including the institutional ones, Uganda prisons, Makerere University Hospital. So that tells you that 99% of the health facilities in Kampala are public. But when you look at health service seeking and who goes where, you go to the public facilities where there are high investments. That means that where do mothers deliver more? Where do people go in terms of trauma? All those conditions that people need high expenditure. People will go to the public facilities. And that's something when you look at the detail. So what I'm getting to is that the private sector tends to invest where the returns tend to be higher and the inputs tend to be lower. So looking at the 50% will actually tell you that in terms of OPD, many people will go to the private sector for the OPD services. Now, when you go to inpatient services, that is when you start seeing the differences of, it goes probably up to 70% of people going to public facilities. And you realize that numbers here won't matter, but where people will tend to go. But also, we have seen that each time there is improvement in quality of care in public facilities, the population that tends to benefit more are the wealthy. So each time a public facility increases on its level of care, and you see the increase in numbers, you see a proportion that the people who are wealthy were the ones accessing that quality. Why? Because they tend to have access to the information or greater access to these places. They will tend to know that probably Emma has done on Twitter, so they will have access to Twitter. They will tend to know Dr. JB, who they can call and say, come, this service is actually there. Now that is where we see, and it is very clear in some of our facilities. We have seen people who walk in with insurance cards, and when you ask them, why are you coming to a facility yet you have an insurance card? And they will tell you that the quality of care is actually better. Now when you look at the KCCA facilities, in terms of even delivery. The deliveries in all the 8 KCCA facilities, these are the health center 3s. They deliver up to 21,000 mothers in a year. I know Rubaga has close to about 4,000. Now, Kisenyi Health Center, which is the health center 4, will deliver 9,000. But even out of the 9,000, there are those who are at that level. So it is not necessarily true that is a vote of no confidence in public health facilities. I think everybody has a part to play. And I always say this is that because of the numbers in the public facilities, there is something going right. You may say people may not have an option, but I believe, being the optimist, there is something we are doing right. So the other about first aid again, and looking at it as part of the curriculum, when you look at the concept of health delivery and what roles everybody has to play, there are the personal health initiatives and there are the community health initiatives. Now, first aid has the beauty of falling in both. Because if you teach somebody first aid, he can be able to, one, administer first aid to himself. But when that person is also in the community, they can also be able to administer it to the people in the community. And again, I'll refer to the message by the former Director General, Professor Mwasa, who said that health is actually made at home, and in the facilities, we repair it. So first aid is part of those personal level interventions, but also that can be scaled up to community level interventions. Now the discussion we should be having is that how do we integrate it across the board in the communities, in the schools, and where people actually are. In other words, healthcare is not a preserve of us who are seated here on the panel. We are all in it, and we all have to play our part. Thank you.
Thank you very much, Dr. Kero. However, there was a question where someone was asking, how can we make EMS services more reliable and affordable? Response time should be less than 10 minutes around Kampala. For example, KCC and MOH should do something. What is the turnaround time for evacuation?
Yes, that's a good question. And again, it goes back to our strategy. Right now, considering the resources we have at hand, and this is where we are moving. We are starting with one, there are also facility-based transfers. And some of the things which make response difficult are inherent to the physical planning or the areas where we are. If you called me and I told you, give me directions to where you stay, you'll take me through a very winded trail. Oh, there is this mango tree, there is this kiosk, there is the border stage. And those are the things that may take me so the inherent things that we need to fix. Now, KCCA, I think about 3 years ago, we underwent a house numbering exercise. And the idea of this was that if each house was given a number, and each time we were giving out a number, we were geo-referencing these areas. So what you needed to do, if you're home or if you're somewhere, was just to be able to get your house number. And once we knew your house number, using the GPS coordinates, it would be very difficult to get there. So some of the inherent things that we are working upon to be able to improve the response time are some of those. But definitely, If it is a facility transfer, because as I said, you did a census and all these facilities are geo-referenced, the time actually becomes less. But again, moving forward, as we are making it lower, KCCA is putting up a traffic control center. Now, all the signalized junctions in the city are going to be managed at one point, and this will be based at KCCA. And the EMS center will also be based at that, very close to the traffic control center. That would mean that the issue of traffic won't be able to have more of an impact on us, because they can then be able to manage the lights and the signals, and someone can get from one place to another without any other challenge. So yes, it may seem high, but there is movement towards bringing it down. But as I say, EMS goes beyond the health sector, and we'll have to correct some of the things that are there.
From Dr. Grace Nanyondo, and also there are some additional questions that came in. Emphasis for statistics on cases of patients who have died due to failure to receive immediate first aid. Emergencies which cannot wait, e.g. neurosurgery at large, due to bleeding, will not reach Mulago arrive. I suggest that we have surgeons from different regional referral hospitals, at least 3 months attachment at Mulago Neurosurgery Department for life-saving skills. That is taken note of. Another one is 99 patrol police are doing a good job of transferring patients to hospitals, but they need some form of training to handle emergencies. That is taken note of. Director Rubaga Hospital weigh in on some of the questions.
Thank you so much, Emma. I'm going to start with a question that said Rubaga Hospital, how does it handle accumulated bills? Does it confiscate people's land titles? And I'm going to say strongly, no, we do not. What we do, we move with our patients. As the bill accumulates, we keep explaining to them. Every day we give them a new bill, and they know how the bill is accumulating. We give them time to ask questions, how it has come, and we explain to them what we have bought, what we have used, and how their bed is a bit expensive, more than the other indigenous patient beds. And we help them pay bit by bit as they are still with us. At the end of it all, if they fail to pay the total bill, we have ways to help them meet these bills. And as we keep explaining to them, they check their financial state. Some reach an extent and said, you know what, please kindly allow us go to Mulago. Where we have reached, we cannot manage to go further. Then we help them go. We transfer them on our own cost. We pay the ambulance. We don't charge them for ambulance. We carry them and hand them over to Mulago, because that is our national referral center. We don't refer to elsewhere. Apart from Zambia, we don't refer to lower centers than us. And then Mulago Hospital, we thank them. They have always handled our patients so well, and they have always received us. Unless this current pandemic, when sometimes it would take long, when the patient is in the ambulance, as they are organizing space to put in this patient. So payment, we have payment terms. If they fail to pay at the end of it all, and the patient is well, is going home, or the patient has died, we involve the administration, the social work team, and we find paying terms that are in agreement with the patients and with the attendants. Some decide they will pay in bits. Others say, in this amount of time, I will have completed the payment. Then there is a team that keeps following up these relatives until they finish, they complete the hospital bills. And that is how we have been able to move on with accumulating bills of the COVID patients. Then I want to add something on Dr. JB about the compassionate of health workers at the emergency unit. This, I want to strongly recommend this term compassionate. In our training, we talk about professionalism more, and we don't mention a lot compassionate, which is a key in our practice. And it is individually attitudes. It is individual attitude. And people keep giving bad attitudes to patients because they did it on one patient and went away with it, and they were not recognized. So they keep thinking it is the way to go. They do it sometimes to dodge work, or other times they are busy and they fail to explain to this patient that, kindly help me first handle this emergency, then I handle you next. Or if this emergency can't wait, then you call for backup from other health workers, from other units that are not very busy. It is about coordinatedness. That I am busy, emergency, I am busy, please come and give me backup. And the team will come and give you backup and help this emergency that can wait. One that can wait, you handle one, finish, and then handle another one. So it is ideally attitude of a person failing to be compassionate, and because this person has gone on doing this thing and is not caught, continues doing it. So this comes up to the public. If me, the supervisor, have not seen this stuff, I will not know. If the public has seen, kindly inform the supervisors, then they will teach or they will instruct this person to go back to the professional behavior. Then another question, how clients die in waiting. It is very sad. I've never seen it, but I saw it during this current wave of the COVID pandemic. We stretched ourselves, we expanded the hospital, but we reached a limit that you could not take in any other patient. Why? Because you have nowhere to put this patient. Because your staff is escalated, you cannot expand anymore. So you kindly advise this patient to go to another hospital. This very patient has moved from several other hospitals when they are full. So what can you do? It was very sad, but that was the situation. Not because they didn't have money or because we didn't want to receive them, but it was the situation elsewhere. Some would opt to die in the way, moving around to look for a facility that can take them, or some would opt to go back home and die. Not because the health facility has refused them, but the capacity cannot accommodate them.
Sister Judith Komhendo, who works with the COVID treatment unit at Mulago, to also respond to the questions. We have run out of time, but the discussion is very important. That's why we have extended a bit. But I will request you to also, maybe if you have closing remarks, you put them across. Thank you. You don't have any question to you, sister? I can recap mainly on how we are handling attitude of the health workers, and also when these patients come, how do we turn around the fixing of beds, etc., to avoid unfortunate scenarios of patients dying in ambulances?
So, thanks so much, Emma, once again. I think Dr. Grace talked it well about the altitude. Yeah, I just started by saying it is somebody's personality. We are different in everything, and we do things differently. And I think we saw why we do it. She has really brought it clearly. We've been having scenarios where we find our triage is full or the wards are full, and we can't admit in these patients. Sometimes we are tired. You know, this pandemic is a second wave. The work has been too much. Accidentally, you can answer somebody rudely and you don't apologize. Automatically, they will take it the way how you've really mentioned it. But we are sorry for that. And we promise that such things are going to stop as we go on. We are sorry, and we are sorry, and we are sorry.
we can have a response from Dr. Annette, and could also tackle the issue of how EMS can overcome the obvious challenges faced in handling and transporting COVID patients, and also any concluding remarks.
All right, thank you very much, Emma. I'll just circle back to Mr. Chobe's question. So from WHO statistics, if you have a well-structured emergency care system, you should avert at least a minimum of 54% of your emergencies from becoming mortality, from dying, really. So Uganda, maybe from extrapolating from our trauma, about 5,000 deaths, between 3, depends, they've been changing between 3 to 5,000 for the past 5 or 6 years. So 54% of that, I think, is quite a good number of deaths, of deaths avoided. How can we avoid the challenges we are seeing with COVID? Of course, each of us has a role to play in managing EMS, preventing emergencies. Please get your vaccines. Please, please, please. Once we get more vaccines, get vaccinated. 2, obey the SOPs. Wear your masks, hand wash, hand sanitizers, social distancing. When there's a lockdown, as we are now, stay home unless you have a critical or essential need to move. So prevent emergencies from happening. When we send out communication, when the PR team, when Emma's team sends out communication, please read those things, save those numbers, and use them when there is an emergency. But also, please know that there are people who are not sleeping, who are working very hard to support you. So please use the public access numbers and reach us, and we will be there to support you as much as is feasible within our health system. And that goes from the ministry team all the way to the health workers on the ground. We're dedicated to saving lives, and we are there to really support all our emergencies. In conclusion, emergencies concern us all. Please play your role, and prevention is really better than cure. Thanks.
Thank you, Dr. We are going to have Dr. JB talk about whether COVID pandemic has affected government strategies on emergency medical services, and also your concluding remarks.
Thank you, Emma. And before I tackle that, I realize there were some other 2 questions which were not tackled. One was every time they receive reports, the government ambulances have no fuel. We feel these ambulances, depending on the allocation of funds from Ministry of Finance and appropriation by Parliament, there are periods when there has been a struggle, but what I can assure you is that this quarter, fuel and facilitation for health workers and all those are available to support the referral of patients, both COVID and non-COVID. So all the about 116 ambulances in the country have been financed under the COVID-19 supplementary budget, and so they will be running across the country. You should get in touch with the healthcare providers, leaders actually, us at the ministry, the hospital directors at Regional Referral Hospital, and the district health officers. All these people, by next week, they will be having fuel to run their ambulances. But those within Kampala, the permanent secretary has always, because COVID-19 hit Kampala too much, the permanent secretary reallocated fuel from other departments to EMS to see that the ambulances keep running to save lives. As you know, 75% of the COVID cases have been around Kampala, especially those who need admission, the moderate, severe, and critical cases. Then the other part I wanted to bring to your attention is that in the Traffic and Road Safety Act, as amended 2020, Section 125A provides for giving care in emergencies without due regard to pay. And it is up to you, the media, to know that that act exists, which requires every provider, be it a private health unit, a private service provider, a public health provider, should offer life-saving care without due regard to pay. Being a road traffic act, it refers mainly to trauma, but that is extended into the Uganda Medical and Dental Practitioners Act, which requires us to give care to save life without due regard to pay. Of course, Sister explained why COVID becomes complicated, because even the life-saving care you are giving becomes very, very expensive. Now, then there was a last suggestion that I think Emma responded, issues of having other surgeons have time in the neurosurgical ward in Lagos so that they can help to manage cases in their regions other than referring. I think we take on that, which will be discussed at higher levels, and we get advice. Back to what Emma's brought out, COVID-19 pandemic has highlighted the need for emergency care services in this country. If you have never known that emergency response is very important, you have known it during this, especially this wave 2 of the COVID-19 pandemic. As Ministry of Health, all the plans which we were going slow on them, we had got to accelerate. We have been training an average of about 40 people annually to respond to emergencies. But due to COVID, as I reported before, we had to scale up and train over 500 in response to COVID. We have been purchasing ambulances annually between 10 and 20. But due to COVID, we had to purchase over 100 ambulances. And yet, when you calculate, in the Ministry of Health estimation of the number of ambulances we need over 460 ambulances in order for us to reach every individual on time. On top of that, we have had effects because the people have been deteriorating at their homes and making calls. The need for a universal access number, which is for the ambulance, became very critical, and we had to adjust so that this number 911 becomes active, and we are working towards that. So the Ministry of Health is pushing that the response to this emergency becomes timely, and in reference to what Dr. Ayen was replying on the timeliness of response to less than 10 minutes. We may not achieve 10 minutes, but within 30 minutes we should be able to reach someone who is desaturating at home. The other part is the realization, like the questions you have asked, the realization that emergency care professionals with the right attitude can make a difference in someone's life. And we are pushing towards having so many emergency care professionals. That's why Annette was telling you about the recruitments. But these people are very few. Critical care nurses, emergency physicians, intensivists. So what government is doing now is to make sure we train more and more people so that we can fill that gap. Also, the Ministry of Public Service has accepted to have the structure, the human resources structure reviewed to provide for these emergency care professionals, which probably would not have happened very quickly if COVID was not there. And the other aspect which I think is going to move very fast is the policy being pronounced on by cabinet, because it's an issue. All of you have been following. Even I want to appreciate so much that you have given us time to discuss emergency medical services. This is an area, as the moderator was saying, which many people take for granted. But this is the time when all of you have decided to think that, hey, let's see this neglected area. From what Dr. Alenyo was giving you, 54% of the mortality in this country can be averted by having a functional emergency care system. So if we invest in improving the EMS system in the country, it means that we are going to cut the mortality rate in this country by 54%. That is a worthwhile investment, which I call upon all of you to support so that we have emergency care as a priority across this whole country. And I have belief that even the delays which have been happening with the policy will move faster because the need is very significant and it is for all of you. And finally, I thank you, Emmanuel, for giving us this opportunity to be here. Thank you so much.
Thank you very much, and thank you to the panelists. I would give Dr. how KCC, ECOR, and dispatch centers contributed to emergency medical service during COVID response. And in case there is a toll-free number that is currently being used, you can also hint about it. And also maybe as we plan to receive vaccines, because we have received a pre-alert that we expect some COVID vaccine, AstraZeneca and Sinovac, on the 30th and the 31st of this month. So what are the centers that have vaccines currently, or have we run out in Kampala? Thank you.
Thank you, Emma. Sometime last year, about April, when the initial lockdown occurred in March, there were directives that were issued, and among those was to make sure that we coordinated conditions that people who did not have COVID should have access to health facilities. And that was the first essence of us sitting down and saying, how can we get to people who have non-COVID cases? Because remember there was a lockdown, people were still falling sick due to other cases. And one of the directives was that all the cars through government were supposed to be parked in the office of the DHO. So what we did was to have a number and use these cars to be able to pick people from wherever they were and take them to health facilities. Now that was not your typical EMS response, but it was one of the innovations of the resilience of the health sector. And from that, because people would call the number, or would pick people from wherever they were and take them to either deliver. There are those who are on long-term care, who needed to go to the Cancer Institute. Then we had those who were attending the diabetic clinic in Mulago, the children. We needed to distribute life-saving medication. Then there are those who were on ARVs who could not make it, and we all had to coordinate that. And when I looked at my data, we actually served more than 10,000 people during the first wave. Now, this was due to the disruption caused by those non-pharmaceutical initiatives that people call a lockdown that we are reacting to COVID. But also, during the first wave, we were putting into care all the cases, both the mild and the severe. And we had to pick people from home. And all this was a coordination, Ministry of Health, and so on. The second wave brought us a totally different aspect to it, because now we needed to evacuate the severely ill. But within the EMS call center, other issues arose that we needed to respond to. In the first wave, there are issues of GBV, because when we went, we thought that, oh, we are only going to deal with medical cases. But gender-based violence came in. People would call and we'd have to respond to that. Mental health issues came in and we had to respond to that. Now, when the second wave did come in, it was now, because home-based care, evacuating those that were severely sick. And again, I was looking at my data from June, from the first lockdown to now. And these are both, when you look at the split between the COVID and non-COVID, COVID is about 52%, and non-COVID is about 48%. But now what we are seeing is that with time, the COVID-related calls are going down, and the non-COVID calls are slowly coming up as the lockdown is happening. So in terms of numbers, those are the people we have responded to. But with the Ministry of Health, we have structured a system, which number actually Dr. Annette read out, 0800990000. The other innovation we are doing is we are testing a WhatsApp number. Because we noted with WhatsApp, you tend to have a more, should I say, a more intimate interaction with the person on the other hand. And once that is done, then we'll be able to also put it out, such that people can also, if you can't call, at least you can WhatsApp and be able to communicate with somebody on the other hand. So just again, summarize, Emma, we have responded to both COVID and non-COVID cases. We have gone beyond to support services like gender-based violence, that we have also, the Ministry of Health, made sure that people can be evacuated from their homes. Closing remarks. Emergency medical services are here to stay. And as I say, the backbone of a strong health system. But they are also, as someone will say in a meal, when you put the right amount of salt, the food tastes wonderful. When you put too much of the salt, the food may not be that well. You put less, the food may also not be that well. So in order for us to be able to be proud of our health system, let us support the EMS initiatives. At least when we live here, can we promise ourselves, all those who are there, let us learn one life-saving skill, one first aid life-saving skill. I can assure you, you're going to save a life with that skill. Thank you.
Thank you very much. Don't know whether Dr. Grace, you have any concluding remarks? Then I would request to know who is going to give us concluding remarks from Twaweza.
Thank you.
Okay, Dr. Grace.
Thank you so much, Emma. And thank you so much for hosting us. And thanks for the organizing team. My concluding remarks is that everywhere in the community, wherever we are, Let's know that COVID is real, COVID kills, COVID needs emergency response, beginning from you who has suffered from it. We all know the signs and symptoms. If you are treated early, you can get cured. If you delay at home, sometimes in terms of I don't have money, you're most likely causing yourself or making the situation so hard to save your life. And then vaccinate when the vaccines are around, and then keep SOPs, and everyone take care of each other. Thank you so much.
Thank you very much, panelists, and thank you for sparing your time off your busy schedules to be with us. I request Violet Alinda from Twaweza to give us also closing remarks, and I can see there's some snack that is ready, so endeavor to grab a snack when we are done. Violet.
Thank you so much, I wish I was there to join you for the snack. Really done a great job. First and foremost, on behalf of Twaweza, I would really like to thank our panelists. Dr. Mambohe, the Commissioner of Emergency Medical Services, Dr. Okello, the Director of Public Health and Environmental Services, Ms. Judith Komhendo, who is representing the NANS and TOT Medics from Lago, Dr. Grace Nanyondo, the Medical Director of Rubaga Hospital, Dr. Annette Alenyo Ngavirano, the Emergency Physician and Technical Advisor, Emergency Medical Services at the Ministry. And of course, to you, Senior Public Relations Officer at the Ministry of Health, Mr. Emmanuel Aineviona. We are really grateful that on a Saturday, given the amount of work and the commitments and the challenges that you're faced with, you're able to set aside time to come and give us all this information, which of course in turn we hope will be shared with others for the benefit of keeping us informed, for the benefit of to share, to see the message of hope, for the purposes of making sure that we are all making our own contributions in a way to avert the bad effects of COVID-19. Also, allow me to thank the media partners that have been able to join us online, but more so those that are able to walk into Africana every weekend for the last 5 weeks. We are really grateful because you've set aside this time and you continue to be the vessels and the vehicles that disseminate this information far and wide to keep everyone informed. And also I'd like to thank the medical professionals that have joined us online. I can tell you, for us as a team, we do appreciate the work you've done during these trying times in very difficult situations. But even when you're tired, even when you have other things, you still find the time to come and join these online conversations. We really do not take that for granted. Also, allow me to thank my colleagues that are able to join in online, some from Kenya, some from the Dar es Salaam office. We appreciate their efforts. But most importantly, the people that are behind the process. Martha, Marie, the team in Uganda, we really appreciate all your contributions. And we are glad for this partnership and for this collaboration with the Ministry of Health. Of course, Ms. Inaviona, when you return to the ministry, kindly deliver our message of appreciation.
Time. Yeah. So
the recording has stopped.
And I also want to record the same message to our panelists, Violet,
Alinda from Twaweza, Mari Nanyanzi Twaweza.
Nambole, Commissioner Emergency Medical Services at the Ministry of Health.
Dr. Ayen Okero Daniel, Director Public Health and Environment, KCCA. Ms. Judith Komhendo, nurse and also TOT epidemics, Murago Hospital. Sister Dr. Grace Nanyondo, Medical Director, Rubaga Hospital. Thank you for joining us. Dr. Alenyo Annette Ngabirano, Emergency Physician, Technical Advisor, Emergency Medical Services. And all those who have joined us via Zoom and also the YouTube live channel. This program is available. Once you click that YouTube channel, you will be able to watch each and everything that has transpired. The journalists who have been present with us here endeavor to take a Luganda version or any other language, depending on the languages my panelists have can able express themselves. And also note that for people who are yearning to be vaccinated, ministry has received a notification that we are likely to have 2 consignments of the AstraZeneca vaccine arriving on 30th July, and also the Sinovac vaccine doses arriving on the 31st. We shall keep you updated with the details on the quantities, and also UNICEF will be able to ship them, and national medical stores will be ready to have them kept in the cold chain system until when they reach the recipients. And we shall also, through our vaccination rollout program, guide on the distribution of these vaccines. So once again, thank you for your time. I've been Emmanuel Ainebiona, and I wish you a lovely weekend. Snack is served. You're welcome.